So good afternoon everyone. I'm Mark Sasagites and we're already on the part 2 of this report which is the drugs for asthma and other pulmonary disorders. So bago tayo mag-umpisa, humihinga pa ba ang lahat? Inhale, exhale muna kayo dyan. Inhale, exhale. Okay. Mabango pa ba? Na-chart. So lang. Let's start. So starting off with the physiology of the lower respiratory tract. So first, balikan natin yung anapin natin. Ano nga bang meron sa lower respiratory tract? So the lower respiratory tract, nag-umpisa to sa trachea down to the alveoli. So the lower respiratory tract consists of the trachea, which is the windpipe, or syempre, ito yung nag-aalaw sa hangin na daling papunta sa lungs. Next is the bronchi. It is formed by the division of the trachea. So next is the lungs, and within the lungs is the bronchioles and the alveoli. The bronchioles, ito yung parang hair-like structures na nagko-connect sa bronchi at saka sa alveoli. So next is the alveoli. Ito yung site for gas exchange. Okay, so next, alamin natin ano nga bang function ng respiratory tract. So first is supply the body with oxygen. So, alam naman natin kung gaano ka-important ng oxygen sa ating katawan. Kasi ito yung oxygen, ito yung nagbibigay ng energy sa mga cells. Yan, gaya ngayon, di ba? Kung walang oxygen, walang mamamatay yung cells, wala rin tayo, di ba? Next, expel carbon dioxide. Kasi yung katawan natin, yung carbon dioxide, yung waste product. Kaya kailangan matanggal sa katawan or else, maaaring magdulot ng serious conditions. Kaya kailangan ma-expel yung carbon dioxide. So next is the ventilation. It is a mechanical process of moving air into and out of the lungs. So sa madaling salita, ito yung breathing or yung paghinga, ventilation. So next, alam ko sobrang sisiw na rin talaga nito sa inyo. Next is inspiration or inhalation. So contraction of inspiratory muscles increases thoracic volume, which results in expansion of the lungs and an increase in alveolar volume. So let's observe. Try natin, di ba? Mag-inhale tayo, di ba? Inhale. Exhale. Exhale. Okay, so diba as we observe, kapag humihinga tayo, nag-expand yung thoracic cavity natin, yung diaphragm natin nagpo-contract. Diba? Next, expiration. Expiration or exhalation. The volume of the thorax decreases as the diaphragm relaxes. Ayan. The diaphragm relaxes as we exhale. Inhale. Exhale. Okay. Yung volume ng thoracic cavity natin nagde-decrease kasi nga lumalabas na yung hangin. So the diaphragm relaxes and air leaves the lungs possibly with no energy expenditure required. So diba sobrang sisiw lang sa inyo. Next is perfusion. Refers to flow of blood to the alveolar capillaries. Yung lungs natin is supplied with blood and yung blood na dumadaloy sa lungs, yun yung tinatawag na perfusion. So para mas maunawaan natin yung process, ito yung let's proceed. So, okay, let's proceed. So, syempre, as we breathe, as we inhale, yung hangin papasok sa ilong, down to the nasal cavity, hanggang makarating sa larynx and trachea. Ayan na, yung trachea. And down to the trachea, dadali niya yan sa left and right bronchi. Okay. And then after ng bronchi, dadali niya yung hair-like structures, which is the bronchioles. Yan, ma-observe ko dyan. And from the bronchioles, dadali niya yun sa alveoli, which is the site for gas exchange. Ayan yung parang mga prutas daw, or yung grapes na tinatawag nila. So, next, yung alveoli. So, yung alveoli kasi, it is rich with capillaries. And alam natin, ano nga ba ulit yung capillaries? Okay, blood vessels yun. And yung blood vessels, syempre, alam natin yun na may arteries and veins. And ayun nga, from alveoli, dahil meron ng capillaries, may blood supply din yun. So the alveoli capillaries would have very thin walls which allow the oxygen to pass from the alveoli to blood. So yung oxygen, pinapas nyo yun sa bloodstream. So ito na, dito napapasok din yung role ng circulatory system. Kasi di ba yung respiratory and circulatory, they work directly to each other. So without the other system, mahirapan mag-function. So di ba from the capillaries, from the alveoli, connect niyo yun sa larger blood vessels, which is yung veins natin. And yung veins, alam natin, yun yung nagkikerry patungo sa heart natin. And syempre, yung heart, ano nga bang ginagawa ng heart, diba, yung nagpapump yun ng nutrients sa katawan, including yung oxygen. So, yung oxygen, pag na-reach yung cells, magpo-produce yun ng energy or magpa-function. Ayan, kaya natin ngayon, kaya tayo buhay. Kasi inhale tayo, exhale, nasusuplayan ng energy. So, next, as we exhale, doon na, ay kasi after nun, yung, di ba, na-produce na yung oxygen, yung waste product na mag-produce din is carbon dioxide. And yung lalabas yung carbon dioxide through exhalation. So, yun lang. Next po.
So next po natin ay ang bronchiolar smooth muscle. Bronchioles are muscular elastic structures whose diameter or lumen varies with the contraction or the relaxation of smooth muscle po. So bronchodilation, ito po yung tawag sa pag-open o pag-open po ng lumen or the small airways in the lungs to allow more air to enter the lungs freely. So as a way po, ito rin yung nakakatulong para ma-increase ang oxygen sa body's tissue. And sa bronchoconstrictions naman po, ito po yung tawag sa pag-tighten ng muscle as a reaction po to certain things sa mga taong may asthma. At kabaligtaran po ng bronchodilation, ito po yung nagkakos ng less airflow sa body. Kaya, di ba po kapag inaatake ng asthma ang isang tao, nahihirapan silang huminga dahil iyon sa airways po na nagiging narrow dahil sa constriction. In addition po, bronchodilation and bronchoconstriction are largely regulated by two branches of the autonomic nervous system, which is yung sympathetic branch nga po and the parasympathetic branch. So, ang sympathetic branch po, ito po yung nag-activate ng beta-2 adrenergic receptors. And as a result po, ito yung time na relax lang ang bronchiolar smooth muscle kaya mas malaki ang diameter ng airway and mas magaan po ang flow ng oxygen sa katawan. While sa parasympathetic branch naman po, it causes the smooth muscle to contract. Kaya as a result po, gaya ng sinabi natin kanina, mas nagiging narrow po ang daanan ng airflow at mas kakaunting oxygen ang naipapasok sa katawan ng tao. Mayroon din pong mga drugs na nakakapag-enhance ng bronchodilation and those drugs po ang nakakatulong din sa taong may problema sa airways nila na para makahinga po ng maayos at ang tawag po dito ay ang bronchodilators po o yung mga drugs na nag-help na mag-stimulate ng beta-2 adrenergic receptors po. And most commonly po, ayun din po ang madalas na pinaprescribe na drugs for treating pulmonary disorders.
So now let's move on to the administration of pulmonary drugs via the inhalation route. So yung respiratory system, it offers a very rapid and efficient mechanism for delivering drugs kasi nga meron itong enormous surface area of bronchioles and alveoli as well as the rich blood supply to these areas resulting in an almost instantaneous o yung mabilis na onset of action for inhaled substances such as medication. So paano nga ba nade-deliver ang mga medication through the inhalation route? So the medication are delivered to the respiratory system by aerosol therapy. So yung aerosol therapy, ito yung administration of drugs using different types of aerosol generators like yung nebulizers, inhalers, and such. So an aerosol, it is a suspension of minute liquid droplets or fine solid particles that is suspended in a gas. So the major advantages of aerosol therapy is that nade-deliver niya yung mga pulmonary drugs to their site of action immediately, which results in reducing the systemic side effect of this medication. Hindi kagaya ng other route of medication such as a route of administration like yung oral route na in order for it to produce an equivalent therapeutic action, the oral drug would have to be given at higher doses and needs to be distributed to all body tissues. Also, aerosol therapy can give an immediate relief for bronchospasm. So ano nga ba yung bronchospasm? Ito yung acute condition in which yung bronchial smooth muscle natin, it rapidly contracts, leaving us grasping for breath. And drugs may be given by the inhalation route to loosen viscous mucus and the bronchial tree. And we need to understand that the drugs that are delivered via the inhalation route has also the potential to produce systemic effects. So yung systemic effects, meaning it affects the entire body rather than a single organ or body part. Example of this would be the neurotoxicity, which means affecting the central nervous system. So yung systemic effects or systemic effect na napoproduce na via the inhalation route, administration of drug via the inhalation route was mainly because of some degree of drugs that are being absorbed across the pulmonary capillaries. Example of this would be yung mga anesthetics such as nitrous oxides and isoflurane or the furane that are delivered via the inhalation route and are rapidly distributed to cause central nervous system depression or the CNS depression. Also, we have solvents, yung mga solvents such as paint thinners and glues that are sometimes intentionally inhaled and can cause serious adverse effect on the nervous system, and in most cases, it could even lead to death. And overall, the drugs that are being administered via the inhalation route for different respiratory condition, it produces minimal systemic toxicity. And we use several devices to deliver these drugs, such as yung mga nasabi ko kanina o nabanggit ko kanina, the nebulizer and inhalers. So now let's talk on these different devices. First would be the nebulizer. So ano nga ba ang nebulizer? So the nebulizer is a small machine that vaporizes a liquid medication into a fine mist that is inhaled using a face mask or a handheld device. So as you can see on the picture, these are the different parts of the nebulizer. We have the mouthpiece, the mask, the nebulizer cup, the compressor tubing, and the air compressor. So we also need to know how to use this nebulizer because it is very important for patient to know how to use nebulizer and inhalers because the absorption rate of the medication varies on that kind of factor. So first is we need to place the medicine into the medication chamber. And then after that, we need to attach the mask in the mouth or the mouthpiece on the medicine chamber. And then after that, we need to connect the tube into the compressor. And then after connecting the tube into the compressor, we need to turn on the compressor of the nebulizer. And then after that, we need to check if there is a mist coming out on the mask or the handheld device. And then we need to inhale the medicine through the mask or the mouthpiece. And after using the nebulizer, we need to turn off the air compressor. So yung nebulizer, ito yung karaniwang nakikita natin sa hospital for asthmatic patient. Sila yung mga maiingay na side bed machine na ginagamit ng mga patient. So, paano naman kapag ang medicine ay solid? So, kapag solid ang medicine that will be administered, we use what we call the dry powder inhaler. So, DPI. So, what is DPI? It is a small device that is activated by the process of inhalation to deliver the fine powder or a fine powder directly into the bronchial tree. So example of this would be the turbohaler or the ND Rutahaler. So as you can see on the picture, we also have different types of DPIs. We have single dose DPIs, the multi-unit dose DPIs, and then the multi-dose DPI. So we need to also know how to properly use this inhaler. And as you can see on the picture, first is we need to open the inhaler and then breathe out. And then breathe in the medication on the inhaler and then hold our breath for 10 seconds. And then breathe out slowly. So meron din tayong, the DPIs could be separated into two. The non-reusable DPIs and then the reusable DPIs, which consist of single-dose system and multi-dose system DPIs. So the last device that is being used for the inhalation route of drug administration would be the metered dose inhaler or the MDI. So ano naman ang MDI? It is a pressured canister or pressurized canister of medicine in a plastic holder with a mouthpiece. Ito yung mga karaniwang nakikita nating on-the-go medication for asthmatic patient. It is a third type of device commonly used to deliver respiratory drugs. So this MDI uses a propellant to deliver a measured dose of drugs to the lungs during each breath. So the patient times the inhalation to the puff of drugs emitted from the MDIs. Now let's talk on the disadvantages of administering aerosol therapy. So one of the disadvantages would be that the precise dose received by the patient is difficult to measure because it depends on the patient breathing pattern in the correct use of the inhaler devices. Even under optimal condition, according to some studies, 10% to 50% of the drug actually reaches the lower respiratory tract. And also, patient must be carefully instructed on how to correctly use these devices, such because it could lead to swallowing those medication that has been deposited in the oral cavity, which may cause systemic adverse effect. So, if this drug has been absorbed in the GI tract or the gastrointestinal tract, yeah, especially if this drug is absorbed in the GI tract, and in addition to that, we need to ask the patient to rinse their mouth thoroughly after using the drug to reduce the potential for absorption of the drug across the oral mucosa. So next would be the advantages and disadvantages of inhalation route of administration. So first is the absorption pattern. So yung absorption pattern of the inhalation route of administration is an example of extravascular administration, na kung saan yung absorption ay nangyayari sa respiratory system through the respiratory system natin through the lungs. And during the administration of medication administration of medication through the inhalation route, there can be some systemic absorption that can lead to systemic side effect. And some study shows that whenever a drug is administered through the inhalation route, the amount of drug that reaches the systemic circulation is less than 100%. But some of the study shows that the absorption will be almost near to the absorption through the intravascular route. So yung variation na to for the absorption pattern is might be because of the variation of the bioavailability of the drugs. So now for the advantages of inhalation route of administration. So first is that it is one of the most important advantages of the inhalation route is that the absorption is rapid or quick. That is why we can see an immediate effect through the inhalation route, which is ideal for gases and inhalation of powdered drugs, making it very effective for respiratory problems like bronchial asthma, COPD, and such. Administration of drugs via inhalation route also has a localized effect that targets only the lungs, and it has a much lower dose compared to that of oral or parenteral administration. And also, the amount of drug that is administered via the inhalation route is very minimal that you can expect a very few systemic side effects. And for the disadvantages, according to some studies, it shows that administration via the inhalation route is the most addictive route as the drug can reach the brain quickly. And most of the time, it is very difficult to regulate the dose as it varies depending on the breathing pattern of the patient as well as their ability to properly or correctly use the inhaler. So that's why it is very important for us to it is very important for the patient to know how to use or properly use or correctly use the inhalers in order for the drugs to be absorbed properly. So next would be the example of drugs that are example of drugs through the inhalation route. We have albuterol, salbutamol, ipratropium bromide, beclometasone, budesonide, and flunitrazide, as well as the fluticasone. So the first two drugs, the salbutamol, it is a beta-2 agonist, whereas the ipratropium bromide is an atropine derivative. And dalawa sila, both of them are used for treating bronchial asthma and COPD. While yung natitira naman, the beclometasone, budesonide, flunitrazide, and fluticasone are all corticosteroids that are mainly used for chronic treatment of bronchial asthma.
Good morning, good day to everyone. So wait lang po natin yung slide. Okay. So now we are going to talk about pathophysiology of asthma. So sino ba dito nakaranas na nagkaroon tayo ng asthma attack? So okay, minsan naranasan natin yung asthma attack kapag tayo ay nai-stress. Minsan naman dahil sa mga infectious diseases. Minsan naman hindi lang dahil doon or bigla na lang nagkaroon. So, alamin natin kung ano nga ba yung pathophysiology of asthma at aalamin din natin kung ano yung asthma. So, sabi dito, ang asthma ay isang chronic conditions. Ibig sabihin ng chronic condition, ito ay pangmatagalan na kondisyon. And sometimes, itong asthma na to, itong sa asthma na to is pediatric disease. Ano nga ba yung pediatric disease? Ang pediatric disease ay, ito naman po ay nagsimula nung early childhood natin. Kadalasan, o most of the time, or most of the patient, pag tinanong mo sila, kailan lang po nagsimula tong asthma po? Nagkaroon po ako ng asthma nung 7 years old po ako, 6 years old, 8 years old, yung mga ganon. So, ito daw ay pediatric disease. Ito ay characterized by acute bronchospasm. So ano nga ba yung bronchospasm? Ang bronchospasm, galing from the word bronchi. So ibig sabihin, broncho at saka spasm. So bronchi at saka spasm. So yung muscles na lining doon sa ating bronchi ay naninikip. So, ibig sabihin, pag nag-tighten yung muscle nun around sa bronchi, sumisikip yung airway na yon. Then, kapag sumikip yung airway na yon, nagkakaroon ng intense breathlessness, nagka-cough, gasping for air. Gumaganon. So, bakit nga ba nagagasping for air yung mga asthmatic patients? It is because nagkaroon ng narrowing of airway. Kapag nagkaroon ng narrowing of airway, hindi enough yung oxygen na napupunta sa katawan natin. So, kailangan ng isang tao na magkaroon magbigay ng effort para makapag-inhale ng enough oxygen to support our body, di ba? Then, nagkakaroon ng bronchoconstriction. So, ano nga ba yung bronchoconstriction? Bronchoconstriction, ito yung acute inflammatory responses natin. It stimulates histamine secretion. Kapag nagkaroon ng histamine secretion, tumataas yung mucus natin and edema in airways, which is also nabablock din or nanarrow din yung airway natin. Then, allergic rhinitis. Ang allergic rhinitis, ito yung airway becomes hyper-responsive to allergen. Ibig sabihin, mas nagiging sensitive yung airway natin sa ating mga allergens. Ano nga ba yung mga allergens? Kunyari, yung balahibo ng hayop, aso, ng pusa, ganon. Yun yung hypersensitive. Yung parang nagiging sensitive yung katawan natin, yung airway natin sa mga ganong bagay, sa mga triggers na nagkakos ng pagnanaro ng ating airway. Sabi dito, both bronchospasm and inflammation contribute to airway obstruction. Tong dalawa na to, sila yung dahilan or dalawang nagko-contribute kung bakit nagkakaroon ng airway obstruction. Ano nga ba yung airway obstruction? Nahaharangan yung ating airway. So, ibig sabihin, nabablock. Hindi lang nabablock, nasisikipan. So, ibig sabihin, nananarrow. So, ang sabi dito, itong asthma natin ay mayroong acute symptoms. At of course, meron naman din siyang chronic symptoms. At itong asthma can cause disorder on excretion. Dahil sa asthma, pwede din magkaroon ng difficulty in bowel movements, katulad ng pag-ihi, paglabas ng dumi, ganon. At itong asthma natin ay natitrigger din siya. So, alamin natin mamaya kung saan siya natitrigger. So, ang status asthmaticus, ito yung severe prolonged form of asthma. Kasi, yung status asthmaticus, etong nako, delikado yan. Bakit? Bakit, Ate Elisha? Kasi, ito ay severe prolonged form at ito ay unresponsive to asthma treatment. Ibig sabihin, hindi na siya nagre-response dun sa drug treatment. Parang hindi na siya nagiging effective yung drug treatment. At dahil dito, pwede mag-cause ng respiratory failure yung isang kliyente natin, yung isang patient natin. So, kailangan dapat alam natin kung ano ng status ng ating client. So, it is important talaga to us, of course, and to conduct medical history. So, ito nga yung mga common triggers of asthma. First, meron tayong air pollutants. So, air pollutants, it can be tobacco smoke, ozone, nitrous, and sulfur oxides, and so on. Pwede din siyang allergens, pollen from trees, grasses, and weeds. Pwede ding animal dander or yung fur ng animal, household dust, mold. Pwede din chemicals and food. It can be drugs, sulfite preservatives, and so on. And pwede din siyang respiratory infectious, bacterial, fungal, and viral. At pwede din siya dahil sa stress, emotional stress or anxiety, exercise in dry or cold climate. So, kaya nga it is important na alamin natin kung ano yung source or kung ano yung nakakapag-trigger sa pagkakaroon ng asthma natin. Kasi, merong specific medicine or drug na in response dun sa cause ng ating asthma. So meron tayong pharmacotherapy of asthma. So sa drug therapy, meron tayong dalawa, terminate acute bronchospasm at reduce frequency of asthma attacks. So, explain ko lang sa inyo guys, paano ba nangyayari kung bakit nagkakaroon ng asthma. For example, this is the bronchi. Is one at dalawa yung ano natin, ganon. So, for example, this is a bronchi. So, airway siya. So, pag tinignan natin siya ditong part, sa asthma kasi, ang nangyayari, yung histamine, nagre-release ng histamine secretion. Kapag nagkaroon ng histamine secretion, nagkakaroon din ng increase sa mucus. Ano ba yung mucus? It can be a phlegma, it can be sticky, fluid, na nakakapagbara sa ating daanan ng airway. Sa ating airway. And then, pwede ding edema, which can cause inflammation sa ating respiratory part. So ano ba nangyayari kapag nagkakaroon ng pagnanaro ng airway? For example, this is a mucus. Papasok ko siya dito. So imagine this one. So imbis na malaki yung yung maayos yung airway mo, sumisikip siya. So ganito na lang yung daanan ng airway mo. So nakahirapan tayo humiga. So ang purpose ng pharmacotherapy of asthma is first terminate bronchospasm. Ano nga ba ibig sabihin ng acute bronchospasm? Yung sanhi ng ating pagnanaro ng ating bronchi, pagnanaro ng ating airway rather. Then to reduce frequency of asthma attack. So ano nga ba yung dalawang purpose ng drug therapy natin? Una, to terminate bronchospasm. Pangalawa, to reduce the frequency of asthma attacks. So, meron tayong dalawa ding klase of asthma drugs. Una, quick relief. Ibig sabihin ng quick relief medication. Parang ano lang siya, SNAP. Ibig sabihin quick relief, mabilisan lang siya. So, under na to, meron tayong beta-2, adrenergic agonist, anticholinergics, and systemic corticosteroids. Then, kung meron naman tayong quick relief medication for ating, for acute symptoms, meron din naman tayo for long-acting medications para sa mga chronic conditions. Tulad ng inhaled corticosteroids, mast cell stabilizer, eucotrine modifiers, long-acting beta-2 adrenergic agonists, methylxanthines, and immunomodulators. So, ano nga ba yung classes of drug attacks? Quick relief at long-acting medications. Ang quick relief, pang mabilisan lang siya, or immediate lang siya. And then, meron naman tayong long-acting medication, pang matagalan, long, ganyan. Then, of course, meron din tayong bronchodilators for treating asthma. So, ano nga ba ibig sabihin ng bronchodilators? Kanina, we talk about bronchi. So, ngayon, dito naman tong broncho. So, ibig sabihin bronchi din to. Ano nga ba yung dilators? So, coming from the root word dilate, ibig sabihin pag-widen. So, ang bronchodilators, ibig sabihin, ito yung mga drugs or medicines na nakakapag-widen ng ating bronchi para hindi sumikip yung daanan ng ating hangin. Okay? Under nito, meron tayong beta-adrenergic agonist. So, ang beta-adrenergic agonist, ito yung bronchodilators for management for asthma at hindi lang for asthma, for other pulmonary diseases. So, probably itong beta-adrenergic agonist, ginagamit din siya sa mga may sakit tulad ng TB. Sa mga nahihirapan huminga, pulmonary diseases, it can be pwede ding related din sa respiratory or related din sa COVID, can be COVID sa pulmonary diseases. So, this is the overview of our drug classes. So, these are the example ng quick relief medication, short-acting beta, adrenergic agonist, anticholinergic, corticosteroid systemic, and then meron tayong long-acting medications. So, meron tayong two common mechanism, bronchodilators, pag-widen natin bronchi, at anti-inflammatory o anti-inflame. So, commonly, ginagamit tong quick relief at long-acting medication to manage asthma and other pulmonary diseases. So, tandaan natin na, excuse me, medyo maingay lang po. So, tatandaan natin, when dealing with this kind of client, hindi lang dapat natin alam yung sources, kung ano, sources or kung ano yung nakapag-trigger sa ating asthma. But of course, to know kung ano ba yung specific medication yung para doon. Kasi we cannot prescribe, hindi tayo pwede mag-prescribe, di ba? Kasi doctor lang yung makapag-prescribe. So tayo, dapat meron din tayong knowledge kung paano tayo mag-a-administer ng drug. So as a nurse, dapat hindi lang puro lang tayo study ng theory, but of course alamin din natin kung paano yung gagawin, para saan to. Kasi we cannot be a nurse na basta bigay lang, and pwede kasi mangyari, mapahamak yung patient natin. Ang asthma kasi guys is delikado din siya kapag napabayaan, no. Lalong-lalo na kapag it can cause death kapag napabayaan yung asthma. Kasi airway yan eh. Tandaan natin sa pag nag-check tayo, lagi natin tinitingnan sa unconscious patient, tinitingnan lang natin yung ABC, airway, breathing, at circulation. So, unang-una yung airway. So, important talaga to na dapat natin malaman to have a fruitful and effective and efficient method sa pag-administer ng drug, and to understand also different drug classes are associated with managing asthma and other pulmonary diseases. So, yun lang po. Hope you guys learn, and sana intindihin lang natin to with our heart, at talaga natin to. Ma-enjoy natin tong class na to. Bye-bye!
So ayan, next is treating asthma with beta-adrenergic agonist. So yung beta-adrenergic agonist, sila yung drugs na nag-activate ng sympathetic nervous system. So kung naaalala niyo sa discussion ko ng physiology of upper respiratory tract, kapag na-activate yung sympathetic nervous system natin, nagko-constrict yung arterioles, nagwa-widen yung airway, tapos mas maraming hangin yung nakakapasok, which relaxes bronchial smooth muscle resulting in bronchodilation. So, yun yung nakaka-lessen or nare-reduce yung stuffiness ng ilong. Ganon. So, yung bronchodilators, yung drugs na yun, yung bronchodilators na, yun yung mga drugs na yun that relax bronchial smooth muscle, thus widening the airway, yung sinabi ko kanina, and making breathing easier for the patient. So, meron ditong dalawang klase ng bronchodilators, yung non-selective bronchodilator tsaka selective bronchodilators. Ito sa non-selective, na-activate yung both beta-1 and beta-2 receptors. So, yung selective bronchodilators naman, na-activate lang yung beta-2 receptors. So, ayan yung table. Ito yung iba't ibang bronchodilators. Andito na rin yung kung saan sila, kung saan yung route, tsaka kung ano yung mga adverse effects. So, ayan. A practical method for classifying beta-adrenergic agonists for asthma is by their duration of action. Meron ditong short-acting beta-agonist na meron ding long-acting beta-agonist. So, itong short-acting beta-agonist, sila yung tinatawag na rescue drugs kasi mas mabilis yung epekto nila. Parang usually 5 minutes lang. Example nito yung nilalagay sa nebulizer, yung tawag dito, itong albuterol sulfate, yung nebulizer solution siya. Yung pag inaatake, di ba, yung mga may asthma, yung ginagamit nila. Ayan, limited lang din siya. Itong long-acting beta-agonist naman, syempre mas mabagal yung niya, yung epekto niya. Tapos, delivered siya via handheld inhalers, and patients may assume they have the same rapid action as short-acting drugs. Patients must be alerted to the dangers of taking LABAs, ito nga long-acting beta agonist, during an acute episode. Although the risk of asthma-related death is small, LABA should be used only as adjunctive therapy for patients who cannot be adequately controlled with other medications. So, hindi sila parang pwede lang siyang gamitin ng mga patients na hindi kaya mag-take ng ibang gamot. So, beta-adrenergic agonists are available in PO, inhaled, and parenteral formulations. When taken for respiratory conditions, inhalation is by far the most common route. Inhaled beta-agonists exhibit minimal systemic toxicity because only small amounts of drugs are absorbed. When given PO, a longer duration of action is achieved, but systemic adverse effects are more frequently experienced. So, mas maraming adverse effects yung PO kaysa sa inhaled. Systemic effects may include some activation of beta-1 receptors in the heart, which could cause an angina attack or dysrhythmia in patients with cardiac impairment. So, ayun lang. Ito yung kaninang an example ko, albuterol. Andito yung administration niya. Yun nga siya, ini-inhale nga siya. Yung nilalagay din sa nebulizer. Tapos, ayan, short-acting drug siya. Tapos, ito yung mga adverse effects niya at saka interaction. Yan lang po.
So now let's move forward to treating asthma with anticholinergics. So anticholinergics are also known as cholinergic blockers or agonists. So it is the drug of choice for treating acute asthma, and it is also an alternative bronchodilator for patients na hindi kaya i-tolerate yung beta-2 adrenergic agonists. So yung inhaled anticholinergics drugs are relatively safe medications, and yung systemic anticholinergic adverse effects are uncommon. So later I will say what they are. So ayan, for anticholinergics, ang prototype drug natin ay yung ipratropium or the Atrovent. Yan din yung sinabi ko kanina for the pharmacotherapy of allergic rhinitis with intranasal corticosteroids. So just looking back, Atrovent is a bronchodilator that is used to prevent bronchospasm in people with COPD, including bronchitis and emphysema. So we'll discuss it further later on. So first, the therapeutic use of anticholinergics. So ito na sabi ko kanina, is to treat acute asthma. The mechanism of action niya, excuse me, it blocks the PNS because the parasympathetic response is largely opposite of the sympathetic response. And so blocking the parasympathetic nervous system may result in action that is similar to those of stimulating the sympathetic nervous system. Now, anticholinergics causes bronchodilation, and it may have a potential pharmacotherapy of asthma and COPD. So for its administration, either of the three, oral, parenteral, or inhalation. Now for its adverse effects, so most of the common patient complaints are dry mouth, constipation, blurry vision. Some also complain of GI distress, headache, and anxiety. Now yung tatlong naka-underline and italicized, which are confusion, impaired memory, and seizures, yan yung serious adverse effects that a patient can experience when taking anticholinergic drugs. So, pag napansin natin yung patient natin experiences to SED3, we have to call for the physician in charge. So, for the drugs, meron tayong tatlo. we have the ipratropium or the Atrovent, tiotropium or Spiriva, and Aclidinium or Tudorsa. Excuse me. So for ipratropium or Atrovent, yung actions and uses niya could be delivered through inhalation or nasal routes. So, yung inhalation form niya ay para ma-relieve at ma-prevent yung bronchospasm na characteristic ng asthma and COPD. Now, Atrovent can be combined with albuterol, which will be Compivent, and yung Compivent na yon is a first-line drug for treating bronchospasms due to COPD, which includes bronchitis and emphysema. And Compivent is prescribed off-label for the disorder. So, ang primary role ng ipratropium ay it serves as an alternative to short-acting beta-agonists and for patients experiencing severe asthma exacerbations. So, it is also sometimes combined with beta-agonists or corticosteroids to provide additive bronchodilation. Yung nasal spray formulation naman ng Atrovent ay para sa symptomatic relief of runny nose that is associated with the common cold and allergic rhinitis. And this drug inhibits nasal secretions but does not have a decongestant action. The treatment is limited to 3 weeks. So for its administration alerts, kailangan lang ng proper use ng MDI or the meter dose inhaler. That is important to the effective delivery of the drug kasi pag nasobrahan, that could be fatal sa patient. So, observation and proper patient instruction in proper use is a must. So, kailangan mag-wait ng 2 to 3 minutes between dosages and we should avoid contact with the eyes sa drug na ito kasi redness of the eyes or blurred vision may occur and it is pregnancy category B. So, sa pharmacokinetics niya at onset, 5 to 15 minutes. At peak, 1.5 to 2 hours. And yung duration niya ay 3 to 6 hours. So, for its adverse effects, so some patient complaints are irritation of the upper respiratory tract that may result in coughing, drying of the nasal mucosa, or hoarseness of the voice. So, it produces a bitter taste. Kaya recommended na after using of the drug, rinsing or gargling is recommended para ma-relieve yun. So, intranasal administration may cause epistaxis and excessive drying of the nasal mucosa. So, for the contraindications, so ipratropium is contraindicated in patients with hypersensitivity to soy lecithin or related food products such as soybean and peanut. Soy lecithin is used as a propellant in the inhaler. So for the interactions, for the drug-to-drug, use with other drugs in this class such as atropine may lead to additive anticholinergic side effects. So, mas lala. Lab tests unknown, herbal or food unknown as well, and treatment of overdose. Overdose with ipratropium does not occur because very little of the drug is absorbed when given by aerosol. So, for the nursing considerations, so pag gumagamit ng face mask yung patient, kailangan siya ayusin para ma-prevent natin yung leakage around the mask. Kasi nga pag nagkaroon siya ng contact sa mata, temporary blurring of the vision may occur and may irritate yung eyes and pwede siya mamula. So, we have also to ensure adequate hydration and control environmental temperature to prevent hyperpyrexia. And have patient void before taking medication to avoid urinary retention and teach the patient proper use of inhaler. Its half-life is 2 hours. So here is the second drug of anticholinergics, which is tiotropium or Spiriva. It actually has a longer duration than Atrovent and is indicated for the long-term maintenance treatment and prophylaxis of bronchospasm in patients with COPD, including bronchitis and emphysema. So it's via oral inhalation, and some of its side effects are acid or sour stomach, bladder pain, congestion, dryness of the throat, headache, runny or stuffy nose, sore throat, and stomach discomfort, upset, or pain. Lastly, we have aclidinium or Tudorza Prefer. It was actually approved in 2012 for the treatment of COPD. Now, its route is oral inhalation as well. So, some of the side effects are paradoxical bronchospasm. So, paradoxical bronchospasm, ito yung wheezing ng patient, lumalala siya, and it could be life-threatening. So, coughing, difficulty in breathing, shortness of breath, if nakita natin yung mga yan sa patient natin, we have to call immediate medical attention. So, next, blurred vision, nausea, vomiting, eye pain, and redness, seeing halos or bright colors around light. So, increased painful or difficult urination or little to no urinating at all. Some more are stuffy nose, sore throat, sinus pain, cough, and headache.
So now let's move on for treating chronic asthma with methylxanthines. So first, what is methylxanthine or what are methylxanthine? Methylxanthines, or simply xanthines for short, are a class of medication that are derived from a purine base that is naturally produced by both plants and animals. So yung methylxanthines, they were considered the drug of choice for treating asthma 30 years ago. So they are primarily preserved for the long-term management of persistent asthma that is unresponsive to beta agonist or inhaled corticosteroids. And they work by increasing the amount of cyclic AMP in smooth muscle tissues, which ultimately leads to bronchodilation. That is why it can be used, or they can be used for the treatment of reversible obstructive diseases such as asthma, chronic bronchitis, and emphysema. So we have different types of xanthine drugs or methylxanthine. We have theophylline, aminophylline, theobromine, and caffeine. So the theophylline, aminophylline are bronchodilators that are chemically related to caffeine. And methylxanthines are infrequently prescribed because they have a narrow safety margin, especially for prolonged use. For the adverse effect of the use of methylxanthine drugs, that would be nausea, vomiting, and CNS stimulation. So CNS stimulation, it means there is an increased level of certain chemicals in the brain that occur frequently, and dysrhythmias, that is an abnormal or irregular heartbeat, that could be observed at high doses of these drugs. And just like caffeine, which is what I've mentioned earlier, methylxanthines can cause nervousness and insomnia. And they also have significant interaction with numerous other drugs. So the mode of administration for methylxanthine drugs would be by oral route or IV route rather than inhalation. And having been largely replaced by a safer and more effective drugs, the theophylline is currently used primarily for the long-term oral prophylaxis of asthma that is unresponsive to beta agonists or inhaled corticosteroids. Now for the mechanism of action of methylxanthine drugs. So methylxanthine theophylline has two different mechanism of action. First is that it inhibits the phosphodiesterase. So as you can see on the picture, if phosphodiesterase is blocked, then there will be a decrease in the hydrolysis of cyclic AMP or the CAMP. Therefore, once there is a decrease in the hydrolysis of cyclic AMP, the amount of cyclic AMP would increase, which leads to bronchodilation. So yung bronchodilation, it is the widening of the airways of the lungs, which makes breathing easier. And then for the second mechanism of action would be that it inhibits the adenosine. And as we can see on the screen, once the adenosine has been stimulated, it will lead to bronchoconstriction. So bronchoconstriction naman, it means the narrowing of the airways, which makes it harder to breathe. So for the effects or adverse effects of theophylline use, we have cardiotoxicity and neurotoxicity. So This is mainly because of the narrow therapeutic index of the methylxanthine drugs. So we need to use this drug cautiously. And we need to always remember that if our patient has a heart problem as well as asthma, then we could not use these theophylline or methylxanthine drugs because of its cardiotoxicity effect.
So, ang next po ay ang prophylaxis of asthma with corticosteroids. Corticosteroids, also known as glucocorticoids, are the most potent natural anti-inflammatory substances known. Because asthma has a major inflammatory component, it should not be surprising that drugs in this class play a major role in the management of this disorder. So, ang corticosteroids daw po ang tumutulong na mag-increase ng production of anti-inflammatory mediators. And although hindi po talaga matatawag na bronchodilators ang corticosteroids, but still, they synthesize the bronchial smooth muscle to be more responsive to beta agonist stimulation. And ang corticosteroids din po ang nagpapabawas ng bronchial hyperresponsiveness, or in other words po, ito ang nakakatulong para hindi agad mag-response ang katawan ng isang tao when faced po with certain allergens na responsible po for some sudden asthma attacks. So, ayan po sa pharmacotherapy of asthma, corticosteroids po may be given systematically or by inhalation. Inhaled corticosteroids po are the preferred therapy for preventing asthma attacks. And when taken po based sa daily schedule, it will help po to suppress inflammation po without producing major adverse effects po. And after the first and 2 weeks of therapy po, possible na makikita po agad yung improvement sa symptoms. And 4 to 8 weeks po may be required for maximum benefit. So, yung mga inhaled corticosteroids po kasi dapat siyang dinitake daily to produce its therapeutic effect. But, of course, let us not forget pa rin po na these drugs na tinitake natin through inhalation are not effective in terminating acute asthmatic episodes in progress po. Kumbaga, tumutulong lang po ito para mas malesen yung sudden attacks po. So, ang local side effects po nito ay ang hoarseness po, dry mouth, cough, sore throat, and oropharyngeal candidiasis. So, para naman po sa systemic corticosteroids, ito naman po ay for severe unstable asthma that is unresponsive to other treatments. Kaya systematic corticosteroids such as oral prednisone po may be prescribed. Sa treatment naman po nito, usually maabot siya ng 5 to 7 days po, and after that brief treatment po, madalas po na pinapag-switch na rin agad ang patient to inhaled corticosteroids for long-term management. Ito naman po kung sakaling sumobra sa 7 days ang treatment at umabot ng 10 days, possible na magkaroon na rin po ng adverse effects, including adrenal gland atrophy, peptic ulcers, and of course the hyperglycemia. For muscle stabilizers naman po, these drugs act by inhibiting the release of histamine from muscles. So, ang adverse effects po nito ay nausea, sneezing, nasal stinging, throat irritation, and yung unpleasant taste po niya. And for leukotriene modifiers po, relatively po, new drugs siya na ginagamit to reduce inflammation and to ease po bronchoconstriction. And as a way po, ito rin po ay ginagamit as an alternative drugs in management of asthma symptoms. Ang adverse side effects naman po nito ay headache, nausea, diarrhea, throat pain, and weight loss.
Okay, so let's move on to the prophylaxis of asthma with leukotriene modifiers. So what is leukotrienes? Leukotrienes are mediators of the immune response involved in allergic and asthmatic reactions. These inflammatory mediators are synthesized by mast cells, same as basophils, neutrophils, etc. So, when released in the airway, it promotes edema, inflammation, and bronchoconstriction. So, what are leukotriene modifiers? So, these are relatively new drugs used to reduce inflammation and ease bronchoconstriction. It is used as an alternative drug in the management of asthma symptoms. Um, and the current role of leukotriene modifiers in the management of asthma is for persistent uh, asthma that cannot be controlled with inhaled corticosteroids or short-acting beta agonists. So, yung leukotriene, siya yung nagko-cause ng inflammation and bronchoconstriction sa ating airways, and then leukotriene modifiers ay made para ma-ease at ma-reduce iyon. Okay, so next slide. We have three drugs that modify leukotriene function. So we have Xylotone, Zafirlukast, and Montelukast. So Xylotone has a rapid onset action of 2 hours. So ibig sabihin fast acting siya, nagkakaroon agad siya ng effect within 2 hours. So we have Zafirlukast and Montelukast, which is parehas na nagte-take ng as long as 1 week para magkaroon ng optimum therapeutic benefit. Okay, so because of this, dahil nga nagte-take siya ng as long as 1 week para magkaroon ng therapeutic benefit, nagiging ineffective na siya in terminating acute asthma attacks. Okay, so these three drugs are all for reducing the inflammation and reduce bronchoconstriction indirectly. So, ito po yung ating prototype drug. So, we have Zafirlukast or Accolade as the prototype drug. So, it is an anti-inflammatory drug for asthma prophylaxis. Pharmacological class is leukotriene modifier. So, take note lang natin yung adverse effects, which can be headache, cough, nasal congestion, or GI upset. Also, it has increased frequency of infections in patients who are older than 65 years of age. So for contraindications, ayun nga, hypersensitivity to the drug, and patients with significant hepatic dysfunction. Also for clients who are chronic alcohol users. Okay, so these drugs are taken PO or orally. And next reporter po.
So, good afternoon once again. We're now on the nursing process focus for patients receiving pharmacotherapy for asthma and COPD. So, here's the nursing process. So, first, for the assessment, prior to administration, we have to first obtain a complete health history. This includes the previous history of symptoms in association to seasons and also foods or yung pagkain kasi merong yung baka yung pagkain na kinakain nila is contraindicated sa therapy na nare-receive nila. Or next is environmental exposure, existing cardiovascular, respiratory, hepatic, renal, or neurologic disease. Also, we have to assess for presence of fever or active infections, pregnancy or breastfeeding, alcohol use, or smoking. We have to obtain a drug history, noting the type of adverse reaction experienced to any medications. Also, next, prior to administration, we have to obtain vital signs, noting its respiratory rate and depth. Third, we have to evaluate the laboratory findings such as the CBC or the complete blood count and hepatic and renal laboratory tests. And next, we have to assess symptoms-related effects on eating, sleep, and activity level. And next, we have to assess for pulmonary function with pulse oximeter, peak expiratory flow meter, and or arterial blood gases to establish baseline levels. Next, for the assessment throughout the admission, first we have to assess for desired therapeutic effects like increased ease of breathing, improvement in pulmonary function studies, improved signs of peripheral oxygenation, and increase in activity levels, and also maintenance of normal eating and sleep periods. So next is the diagnosis. Okay, below are the probable or potential nursing diagnosis for patients who are receiving pharmacotherapy for for asthma and COPD. So first is the ineffective or impaired gas exchange. Next is ineffective tissue perfusion. Next is anxiety. Next is disturbed sleeping pattern related to adverse drug effects. Next, we have the deficient knowledge because of the drug therapy. And lastly, the activity tolerance. So next, for the planning, the patient goals and expected outcomes. So the patient will be able to experience therapeutic effects, like example, decreased nasal congestion and drainage, increase in ease and expectorating mucus thinner secretion. Second, be pre-prone or experience minimal adverse effects. Third, verbalize an understanding of the drug's use, adverse effects, and required precautions. Next, the patient is expected to demonstrate proper self-administration of the medication, example, dose, timing, and when to notify the provider. So for the implementation, we have two, ensuring therapeutic effects. So under the ensuring therapeutic effects is we have to continue the assessment as described earlier for therapeutic effects. Like yung paghinga nila, nag-increase ba, wala na yung congestion, mga ganon. And lessen adventitious sounds, improve signs of tissue oxygenation, and normal appetite. Eating and sleep patterns should also occur and observed. The healthcare provider should be notified if symptoms worsens. And under this, teach the patient to supplement drug therapy with non-pharmacologic measures such as increased fluid intake to liquefy and assist to mobilize mucus and reduce exposure to allergens where possible. Next, under the ensuring therapeutic effects is monitor pulmonary function periodically with pulse oximeter. Kasi mahalaga yon to assess kung effective ba yung therapy na ginagawa sa kanila. Kaya kailangan consistent and periodically ginagawa yung assessment ulit. So next, to abort an acute asthmatic attack, inhaler therapy should be started at the first sign of respiratory difficulty. For preventive therapy, long-term bronchodilation by inhaler or orally will be used. So, provide explicit instruction on the use of quick-acting versus long-acting inhalers. Teach the patient to use quick-acting inhalers as the earliest possible appearance of symptoms. Long-acting inhalers oral therapy may be used to maintain bronchodilation, but do not discard quick-acting inhalers with one long-term maintenance therapy. Okay, so next, under the implementation is the minimizing adverse effects. So under the minimizing adverse effects is continue to monitor respiration, like the rate, the depth, the breath sounds, the mucus production, increasing dyspnea, adventitious breath sounds, signs of tissue hypoxia, anxiety, and confusion. And if this occurs, it should be reported immediately. So what we have to advise or instruct the patient is to immediately report symptoms of deteriorating respiratory status, such as increased dyspnea, breathlessness with speech, increased anxiety, or orthopnea. Next, under the minimizing adverse effects is monitor eating and sleep patterns and the ability to maintain functional ADLs. Provide for calorie-rich, nutrient-dense foods, frequent rest periods between eating or activity. So what we have to do is to teach the patient to supplement drug therapy with non-pharmacologic measures, including yung pag-take nila ng maraming tubig or fluids kasi doon parang mas napapalambot or nanilikupay yung mucus. So next, we have to instruct the patient to consume small frequent meals of calorie and nutrient-dense food to prevent fatigue and maintain normal nutrition. Next, we have to teach the patient to get adequate rest periods between eating and activities. Next, we have to decrease the room temperature for ease of breathing during sleep. And also, we have to reduce exposure to allergens where possible. Instruct the patient to immediately report any significant change in appetite, an inability to maintain normal intake, inadequate sleep periods, or an inability to carry out required ADLs. So next, um, under the minimizing adverse effects is maintain consistent dosing of long-acting bronchodilators, like consistent dosing with LABAs, anticholinergics, muscle stabilizers, and corticosteroids is used to prevent or limit acute bronchoconstrictive attacks. So what we have to do is to teach the patient the importance of consistent administration of bronchodilation therapy to prevent acute attacks. And under the minimizing adverse effects is we have to assess the patient understanding of drug therapy. So we have to use the opportunity during the administration of medication and during assessment to provide patient education. So, so next, the patient should be able to state the reason for the drug, appropriate dose and schedule, and what adverse effect to observe for what and when to report them. So next, and also lastly, for the minimizing adverse effects is we have to uh, patient self-administration of drug therapy. So when administering the medication, instruct the patient or any family or pwede yung caregiver in the proper self-administration of the drug. Example, take the drug first, take the drug at the first appearance of symptoms before symptoms are severe. So proper administration increases the effectiveness of drugs. We have to teach the patient to recognize the difference between quick-acting and long-acting inhalers and know when each is to be used. Also, we have to instruct the patient in proper administration techniques for inhalers, followed by teach back, including use a spacer if instructed between the MDI and the mouth. If using bronchodilator and corticosteroid inhalers, use the bronchodilator first and wait for 5 to 10 minutes, then the corticosteroid to ensure that the drug reaches deeper into the bronchi. Next, we have to rinse. We have to teach the patient to rinse their mouth after using any inhaler. And also, we have to teach and instruct the patient to rinse the inhaler and spacer with water at least daily and allow to air dry. So for the evaluation, evaluate the effectiveness of drug therapy by confirming the patient goals and expected outcomes have been met. So that's all for the nursing diagnosis for patients receiving pharmacotherapy for asthma and COPD. So next po.
So now let us discuss the prophylaxis of asthma with mast cell stabilizer. First, let us define what is mast cell stabilizer. So mast cell stabilizer are basically agents that prevents the release of inflammatory mediators. So once na-reduce yung inflammation, malalasen yung chance na magka-asthma attack pa. So meron dalawang gamot na naka-classify as mast cell stabilizers. So unahin mo natin yung cromolyn. Cromolyn is the first mast stabilizer discovered and it is administered by several routes for indication. Ang pinaka-common ay through inhalation and with the utilization of nebulizer. Ginagamit lang ang cromolyn before exposure sa mga condition or substance na maaaring mag-trigger ng asthma. So, ayan, nakalagay sa ating note. So, ano ba yung mga substance or condition na yun? Conditions such as fever and sudden change of weather, and substance such as pollen, house dust, and the likes. So, yan, ang adverse effects of cromolyn includes stinging or burning of nasal mucosa, irritation of throat, and nasal congestion. So, yan. May note din dito na hindi nakakatulong ang cromolyn kapag ina-atake na ng hika. So, it is advised to use just before the attack happens. So, next naman ay yung nedoxramil. It has a similar action, use, and adverse effect with cromolyn. However, nedoxramil has longer half-life than cromolyn. So, recall lang, with regards sa half-life. So, half-life means oras kung kailan mag-reduce yung active substance ng drug sa katawan into half. Kaya half-life. Anyway, going back. Dahil nga mas mahaba ang half-life ng metoclopramide, mas less frequent yung dosing kaysa sa cromolyn. So, ayun lang tungkol sa part ko with regards sa prophylaxis of asthma with mast cell stabilizer. So, thank you for listening. Next reporter.
The next topic na i-discuss ko naman ay ang monoclonal antibodies for asthma prophylaxis. So before we delve deeper sa mismong discussion, bigyan ko muna kayo ng very brief background about monoclonal antibodies. So originally, yung term na monoclonal antibodies, yan ay common sa discussion ng anti-neoplastics or sa drug therapies related to cancer. Dahil itong mga antibodies na to, konektado siya sa tinatawag na target therapy, which is a therapy engineered to attack cancer antigens. Yan, ibig sabihin, merong tinatarget na cells or merong specific cell na kakabitan or mag-a-attach doon yung antibody na yon. Ayan, katulad dyan sa nakasulat, monoclonal antibodies are designed to attach to a specific receptor on a target cell or molecule. So, dito sa respiratory system na topic, merong antibody na na-approve to treat asthma or ayun, merong antibody na na-approve dati noong 2003 para sa paggamot ng asthma. And this antibody, it's called omalizumab or Xolair. Ayun. Yun yung pronunciation. I don't know if correct siya, pero naka-flash sa screen nyo yung word. So, etong omalizumab ay isang anti-IgE antibody for asthma. Tapos, ito din ay approved for treating allergic rhinitis and moderate to severe persistent asthma. Ito yung para sa mga patient at least 12 years of age who cannot be controlled satisfactorily with inhaled corticosteroids. So, bale, alternative siya sa inhaled corticosteroids. And then, it is also reserved for patients with persistent asthma, katulad na nabanggit kanina, because of its expense, potential adverse effects, and the need for regular parenteral injection. So, bale, itong omalizumab ay may scope siya na mas malawak. Kaya, reserved siya for patients nga na may persistent asthma. Ito nabanggit dito sa slide na to, yung parenteral injection. So, ang omalizumab ay ang route of administration niya is subcutaneous. So, meaning, i-administer yung drug under the skin into the tissue layer between the skin and the muscle. So, itong injection na to ay nakaschedule siya every 2 to 4 weeks. Pero, depende pa din siya sa magiging response ng patient sa therapy. Kasi syempre, lagi nating i-put first yung kakayanan ng katawan ng patient sa magiging therapy na ibibigay natin. So, katulad ng ibang drugs, meron din tong adverse effects. And for serious adverse effects ng omalizumab, nandyan pa din yung anaphylaxis, yan, merong bleeding-related events, and pwedeng maka-experience ng severe dysmenorrhea. Pero at the same time, pwedeng less serious adverse effects naman yung ranasan ng patient. So, example niyan, pwedeng maka-notice ng rashes or rash sa skin ng patient. And then, katulad ng ibang drugs, common syempre yung headache. So, pwedeng experience ng headache yung patient. And then, possible na magkaroon or makitaan ng viral infections yung mga patient na nag-take ng omalizumab. Ayun, that's it for antibodies or monoclonal antibodies for asthma prophylaxis. Next reporter po.
So now we're going to talk about the last topic, which is the pharmacotherapy of COPD. COPD is a progressive disorder treated with multiple pulmonary drugs, bronchodilators, expectorants, mucolytics, antibiotics, and oxygen may offer symptomatic relief. And the three specific COPD conditions are asthma, chronic bronchitis, and emphysema. The chronic bronchitis and emphysema are strongly associated with smoking tobacco products and, secondarily, breathing air pollutants. So, for chronic bronchitis, it is the production of excessive mucus in the bronchial tree due to inflammation and irritation from tobacco smoke and or pollutants. The airway becomes partially obstructed with mucus, thus resulting in the classic signs of dyspnea and coughing. And an early sign of bronchitis is often a productive cough or on awakening, and gas exchange may be impaired, thus wheezing and decreased exercise tolerance are additional clinical signs. So, itong chronic bronchitis na ito ay syempre, unlike what I've said, ay yung pagproproduce ng mucus sa ating bronchial tree. And ayan ay nag-occur siya for at least 2 consecutive years. 3 months to 2 years. So, yun. Microbes thrive in the mucus-rich environment, and pulmonary infections are common. Because most patients with COPD are lifelong tobacco users, they often have serious comorbid cardiovascular conditions such as heart failure and HTN. So, ayun nga, dahil nga madalas dito sa COPD ay ang mga pasyente ng COPD ay madalas talagang mga tobacco users o yung mga smokers. So, kadalasan kapag may mga ganitong like this na chronic bronchitis, magko-connect siya agad or parang magiging effect niya agad kapag nagtagal ay cardiovascular issues or conditions. So, next. Next is we have the emphysema. Emphysema is a COPD progressive terminal stage na ito. And ayun nga, after years of chronic inflammation, the bronchioles lose their elasticity and the alveoli dilate to maximum size to allow more air into the lungs. The patient suffers extreme dyspnea from even the slightest physical activity, and that the clinical distinction between the chronic bronchitis and emphysema is sometimes unclear because patients may exhibit symptoms from both conditions concurrently. So, itong emphysema naman, ito yung madalas na pagkakos ng shortness of breath natin or yung dyspnea. Pero dahil nangyayari yon kasi yung mga bronchioles natin hindi na siya elastic or hindi na siya parang flexible para maghinga ng normally na huminga. So, kadalasan sa mga patients with emphysema, konting galaw lang, konting kilos lang, nahihirapan na agad silang huminga. And ayun nga, yung mga spaces para sa lungs natin, sa loob ng mga lungs natin, imbis na maging mas malaki siya, hindi na siya nagiging elastic. So, nagiging maliit na lang siya, kaya yun yung pinaka nagkukos ng paghihirap ng hinga. So, yun. And for the pharmacotherapy of COPD, the goals of pharmacotherapy of COPD are to relieve symptoms and avoid complications of the condition. And the various classes of drugs are used to treat infections, control cough, and relieve bronchospasm. And most patients receive bronchodilators such as ipratropium, beta-2 agonists, or inhaled corticosteroids. And for mucolytics and expectorants are sometimes used to reduce the viscosity of the bronchial mucus and to aid in its removal. Long-term oxygen therapy assists breathing and has been shown to decrease mortality in patients with advanced COPD. And one of the newer treatments for severe COPD is roflumilast, a drug approved in 2011 that exhibits anti-inflammatory effects on the airways by inhibiting the enzyme phosphodiesterase 4. Roflumilast is indicated only to reduce the incidence of COPD exacerbation, and the drug should not be used to treat acute bronchospasm. And patients with COPD should not receive drugs that have beta-adrenergic antagonist activity or otherwise cause bronchoconstriction. Respiratory depressants such as opioids and barbiturates should be avoided, and it is important to note that none of the pharmacotherapies offer a cure for COPD. They only treat the symptoms of a progressively worsening disease, or this explains na hindi talaga siya nagpapagaling ng COPD. Ang ginagawa lang ng pharmacotherapy ng COPD ay ma-less yung pinaka-symptoms or yung mga effects na maaring ma-encounter para mag-worse yung sakit. And then, we must strongly encourage our client with COPD na mag-stop ng kanilang smoking kasi smoking cessation has been shown to slow the progression of COPD and to result in fewer respiratory symptoms. So, gaya nga ng sinabi ko kanina, madalas na pasyente dito sa COPD ay mga smoker or mga heavy smoker. So, dapat we will try our best to stop them, to encourage them na mag-stop na mag-smoke. Kasi syempre kapag kunwari nagko-continue pa siya ng smoking habang nagte-take siya ng mga kung ano-anong mga drugs para maiwasan yung mga side effects or yung symptoms from COPD, wala ding saysay yung mga yun kung magko-continue pa silang mag-smoke. And ayun nga. And here we have the lifespan consideration for pediatric. So we have here the respiratory distress syndrome or RDS. It is a condition occurring in the premature babies in which the lungs are not producing surfactant. Surfactant forms a thin layer on the inner surface of the alveoli to raise the surface tension, thereby preventing the alveoli from collapsing during expiration. If birth occurs before the pneumocytes in the lung are mature enough to secrete surfactant, the alveoli collapse and RDS results. So, ayun na, ang kadalasan dito ay mga premature babies, ang mga pasyente. And of course, dahil na premature pa sila, hindi pa fully formed yung kanilang lungs para mag-produce ng surfactant. And surfactant naman ay ito yung foamy siya na ito yung mga foamy substances para nakatulong siya sa pag-work or sa pag-release ng surface tension ng ng lungs. And at the same time, ito yung nagpapa-help sa mga premature babies na huminga. And ayun, surfactant medications can be delivered to the newborn either as prophylactic therapy or as rescue therapy after symptoms develop. Surfactant drugs used for RDS include calfactant, beractant, poractant alpha, and ducinactant. And these drugs are administered via intratracheal route every 4 to 6 hours with improvement generally noted within 24 hours. And that is it for our report. This has been the Group 3 for the respiratory system. Thank you so much po for listening.